whatever I have seen discussed by Prashant, Arvind, these things are very much required in the government hospitals. But we have gone through the budget yesterday only. How much budget is kept for the health? It is a bigger 0.4% of the GDP. So how can we reduce the cost by introducing this IT and all other parameters which are essential, as Arvind has discussed, as Prashant has discussed, that all equipments we can, as with the medical equipment, these printers and toners and all these things. So I request my panelists to discuss one by one, give 10 minutes on this topic, give their inputs, how we can do this. I will start.
Thank you very much, sir. So it's good that I've started because I'll start at the extreme other end of the spectrum. So this is about digital and technology and how we can help the community to access it. So we'll start with those who really need to access it. So the rural community, the villagers, the people living in the semi-urban areas. I feel that IT can really help them to connect to doctors. We have, as we all know, an acute shortage of doctors. We work in the semi-urban areas quite a lot, and we really find it tough to get good doctors to work in those areas. For example, if you see, we have 30 million cancer patients in India, and we produce only 84 DM oncologists every year. We have 60 million diabetics, and we produce only 67 DM endocrinologists every year. So it's impossible for them to go out to the community and see all these patients. So I feel it's very important to use technology to connect them to the community and see how we can help the community to access, to really work towards it. This is the first thing I want to point out. Second, as you said, that the cost savings that we need to put in. I feel there is a lot of scope in that. If we use our HMS and HIS in a uniform way. I've worked in London quite a lot with the NHS recently. I was there for a fellowship. And it's amazing to see how they have all these uniform systems across all their hospitals. You can share your patient records seamlessly if you're moving from one practice to another, or if you're getting into an emergency and admitting your patient in an emergency, your GP can seamlessly share your records with the consultant there, so that the consultant really doesn't touch the patient very cold, right? He knows the background of the patient, he knows how he's been visiting the GP, what problems he's been having. So if we could have some sort of uniformity, some sort of a overarching regulatory body like the Quality Council, that we have to impose some uniform quality standards. If we could have some uniform HMS or HIS standards so that we could talk to each other across hospitals and across platforms, that could save a lot of patients and a lot of costs on unnecessary repeat testings, repeat consultations. If we could use these softwares properly, I think a lot of things could be seamlessly integrated into each other, like purchases, like HR management. A lot of these things I feel can be worked into the system so that the entire community can work. We do a lot of pilot studies on telemedicine, so that I also wanted to talk about. We've seen telemedicine was a very hot topic in conferences around 10 years back, and then it started slowly fading away, and now nobody talks too much about telemedicine. I feel there was a problem that we were trying to do telemedicine from too far across. We are not really very well evolved, and I feel the technical experts can maybe answer if this question is too ahead of its time. But as a previous speaker said, the most technical thing that we were exposed to earlier in our times was a television. And our grandparents were amazed to see that something could be live projected out. to a person sitting in a room and he could see and hear. So I think we are using only the two senses even now in the last 40, 50 years. A live sensory input can be accessed only by two of our senses, that's seeing and hearing. So if we could someday take it forward to touch and feel as well, I feel that telemedicine consults would be much, much easier to do. And I don't think technology is too far away from it. We can do it someday, I feel very sure about it. So then we can maybe really use the doctors and maybe even the chefs to project their talent across the world, like we are doing singers and actors now. They can project one singer, or an actor can project his talent to billions of people across the world. But a doctor or a chef or a person who has to use the touch and feel in addition to seeing and hearing, he is limited by this technology limitation that he cannot really project. So I feel these kind of things, if we can talk about, we can talk about telemedicine in the next level. We have only 30 or 60 super specialists every year, but for the 650,000 villages across India, we have more than 1 million ASHA workers. If we could just train these ASHA workers to use technology well and interact with doctors, maybe we can use them as the touch and feel touch points till the time technology allows the doctor sitting around 100 or 200 kilometers away to use them. So these are the points that I am making, because we work in the semi-urban areas quite a lot. We face these things. I'm sure the technology specialists here can answer some of them. Thank you.
In 1 minute, you tell me the legal aspect of telemedicine. As I am sitting in ethical committee and DMC, so I am getting such a kind of problems.
So I think there's a quite a grey spot there. There are some discussions going on still about whether it is legally valid to issue OPD consults and prescription papers on the basis of a teleconsult. I hope the government can clear it up for us in the future. But I feel that if you're doing it as a follow-up, not as a first patient. So what we do in our telemedicine units, like we do in Panipat and Kurukshetra in our hospitals, is we identify some big villages which are around 20 to 30 kilometers away only. So in follow-ups, if the patient, a patient is consulting a physician for diabetes, his blood sugar is just going up and down a bit. So for a follow-up, he feels that, I need to travel these 20 kilometers, hire a jeep to go, it will cost me a lot of money. So he disregards it. And I'm sure we all know that a complicated diabetes patient spends approximately 8 times more money on his diabetes management than a simple uncomplicated diabetes. So if he cannot control his blood sugar, he will go into nephropathy or neuropathy, or he will develop some retinopathy, and then he will spend a lot of money trying to correct it, which would have been easily corrected if his blood sugar levels had been simpler managed. And if he could have just gone to the next door clinic in his village and talked to the doctor at 2 p.m. He knows that the doctor is available on the screen at 2 p.m. He would just talk to him, doctor, my sugar is 250 now. What do you suggest? Can I increase the dose a bit? And doctor says, okay, increase it. And if the doctor feels, no, I'm not really confident about what the problem is, can you just come 20 kilometers? It's just a half an hour drive. So I think in that cases, the telemedicine will be much more successful. If the patient is not satisfied, I'm not really happy with, on the screen, my ache is not going away or my wound is not healing, can I come and see you? So you can say, yeah, come on. It's not like you're traveling 600 kilometers. So I think that way it's much more easier to do a follow-up or a post-operative consults rather than just seeing the patient up front only on the screen.
Thank you. But I tell you one thing, the legalization of telemedicine and all this is still required at government level. I'll request my second panelist to give his views. First of all, he will introduce himself and give his views. How can we minimize by this communication and all that, all the negligent part which the doctors are facing? No corporate is left in doing all these things. It is an essential part of communication between doctor and the patient, so that we can reduce negligence as much as possible.
My name is Vineet and I represent Fortis Healthcare. I believe it was good that you started off the session because you actually touched a lot of aspects, and in a way I guess you represented the rural medicine as well. So that was a good way to start off. Dr. Lekhi, you mentioned as in the beginning about the budget and the cost that is, or money that has been put to healthcare. It's unfortunate that because most of the time technology is always attributed to the cost, because most of the time the deployment of technology actually costs a lot, and you measure the cost of technology just as the piece that you put in and the cost of implementing it. Sometimes if you just look at it a little beyond and see what all is it going to bring to table, and you realize that the cost invested is most of the time recovered very quickly. And when you talk about a sector like healthcare, it is not just about getting the money out of the investment. It's sometimes saving lives, most of the time saving lives, saving, like you said, accelerating the improvement that or the health of the patient and so on. So the cost aspect sometimes plays a spoil sport, but I guess most of us will start looking at it as in a holistic view, and rather than just looking at the cost that's one. Yes, because he asked me to touch upon that specific thing, I'll just go into that straight away. Technology can definitely play a large role in not just arresting negligence and to ensuring that the patient gets the right treatment. But before doing that, I guess most of us are right now in a phase where we're trying to get some kind of uniformity in our processes. Because if you don't have a uniform process across your hospitals and your institutions, you actually cannot go and implement any technology. So first get the processes uniform, and that will definitely bring a lot of quality and a lot of I'm sure that will bring a lot of patient delight, as the topic actually suggests. If you don't have a uniform process across your healthcare, and if you are not able to monitor that, you will not be able to do this. So first thing, get that right, and then what most of us are now trying to do is, or will have to do to actually get the topic that Dr. Lekhi asked me to talk about correct is actually track the medicine from the time it comes into your hospital to the time it's administered to the patient. So talking about the right medicine at the right time and the right dosage to the right patient. It may sound very strange, but actually the medicine to the patient is also very critical, because it's right now most of this is manual. So technology in a very simple way can play a role. We started off by having barcodes to patients. We have barcodes on your medicines. Now it's just a matter of relating all this put together and tracking the patient's data to ensure that whether at the moment the registration, most of the HIs now have placeholders to track the patient's allergy. But I don't know how many of us actually do it. So we just have to be very sure that the data capture ensures the allergy tracking is monitored, and the systems can be put very simply in place. But at the moment before the medicine is actually administered, it's perhaps scanned to something onto a computer or a laptop or a small device kept next to the bed, which immediately alerts the nurse whether the medicine is right, whether it's the right dosage, whether it's being given to the right patient. So that's one thing that came to my mind when you mentioned that, Dr. Lekhi. Otherwise, I also want to just mention about not about telemedicine specifically, because it's like I heard, not sure about the legality of it. But there are a lot of things that even now simple technologies can provide. Like you said, the doctor being at a particular time on call or on a video for a patient to ask questions. We have seen most of our hospitals do what we call as e-critical care, where the intensivist is there in one of the hospitals, and he is able to attend to a very serious patient or a trauma patient that's come to a hospital which is far off, and that way bring more productivity. We cannot afford to have, many of the hospitals cannot afford to have intensivists around in all their hospitals, or even many of the small hospitals cannot have it. There could be more collaboration between the hospitals, big and small, and bring perhaps support the smaller hospitals in ensuring that the intensivist is supporting the patient. So there are various things that can be done, various innovations in this place which can happen. I also thought that just touching upon some of the aspects, like you said about the ASHA workers. Instead of bringing in too many things, most of us have got mobiles. And I heard somebody in the earlier session speak about how mobile can actually revolutionize this. Mobile is almost everywhere. Most of the other sectors have used, banking has used mobile like nothing like it. They extensively use mobile. Healthcare can also use it. The only bit is obviously we cannot use it to administer medicines. We can obviously give it to capture information, perhaps get more information from the doctors or the experts around, and support these ASHA workers to deliver better healthcare to people. Yeah, so I guess I covered some of your subjects. Dr. Likhi, am I good? Yeah, thank you.
Thank you, sir. Yesterday there was headline in the newspaper, Samriddh Gaon, Sashakt Bharat. As government is saying, there is shortage of doctors. On the other hand, government is saying doctors are not going to villages. I request to my third panelist, how this technology can help the patient, the poor patient in the villages. Still we are lacking in this technology in our metro cities, even in the corporate hospitals, which I am seeing it. Basically, I am looking after 34 dispensaries and 4 major hospitals as chief administrator. So, still our country is lacking in this technology, rather the shortage of doctors and technology we are talking about, how we can help to provide this basic technology in villages as well as in corporations.
Thank you. My name is Kapil, and that's a very relevant topic where I have been worked upon it and did some research. So I'm just sharing my experience, what I learned with that research. See, it's very difficult if you talk in an Indian scenario. 60% villages, they don't have a right network there, right? That's the first challenge which we have. Awareness is another challenge. Third is interest of healthcare organization or practitioners to go there, right? Now these days, a lot of programs has been started. Government taking initiative. They are motivating. They are sending there. There are a lot of innovation is also happening. So I like to touch upon few points. First thing is like how villages can basically be the part of it, right? So you need a lot of digitization, you need a lot of innovation on it, and definitely technology minus network. So something you have to build upon which should not be run on a network. Actually, we should work on an offline, right? In a similar way, as like in our hospitals, everything is working similarly. If same experience people are carrying there, that has to work there, but in an offline mode. Secondly, so we can eliminate network part and we can basically build that kind of capability and give that kind of experience and expertise there itself to the required people. Second is the interest. How we can build the interest to go doctor there. Now, like what I learned in a 2 years time, people are very much open. Practitioners, I really appreciate practitioners. They are coming forward actually by the policy or by the initiative himself. They are coming up. So a couple of examples I like to give you: the Chennai happening, the Jammu and Kashmir happening. Right there, I learned. No hospital basically requested doctor to come. Doctor himself came and they have nominated himself to basically support to that cause. Right, that's why I learned it. So same experience I'm sharing it. So now these days, people know the crux, what they require actually, but the only thing is initiative is required. So there are a lot of, now I'm coming to the innovation. What all the innovations are happening around this? Now e-ICU is coming, mobile vans are coming, right? A lot of new technologies, a lot of ways are coming in right now. So these all are the devices, these all are the things which are highly equipped with the devices, right? As anybody is walking in the hospital and going for the X-ray, MRI, mammography, CT, everything is there now. So one van directly going to the village, let's say one time in Rajasthan, one time in Haryana, one time in Punjab, somewhere, and basically helping to the people actually. Yes, of course, there is no network, so everything is getting offline, recorded. Some of the helping staff is going and they are bringing back data to the office, and they are working on, they are giving us consultation on the next visit or probably over on a phone, some way like people have defined the mechanism. So this is what like in a whole 2-3 years like I learned it. There are a lot of, yes, now government, I'm coming to the government policies. Government is very open now these days. If you have a right idea and you have a will to do that, they are basically ready to design the new policies. They are open. Yes, of course, because the system we have, it's not a straight through system. Something will take time, but definitely things are moving on a positive way. Now coming to the digitization part. With the help of digitization, definitely you can reduce lot of cost, running cost, and the cost which is basically occurring year on a year. I'm giving a typical example. There is a technology where we have been worked on, and it's very open and very cheap, available in the market. That's basically document management system. There is a clear guideline of the MCI, Medical Council of India, says that you have to have records in premise for the next 3 years, physical. If it is a medical legal cases, so you have to retain that record until that issue will not resolve. So you cannot destroy that information, right? But those information are not required, those cases are closed clearly, they can be destroyed after 3 years. This I was not aware. Again, I did a lot of research, but I have contacted to MCI people and got the clear indication. This is the para 34A where they have mentioned this thing, something like that. I just forget the exact para, but something like that they mentioned to me. And I gone to the website, it was mentioned there, right? Then like towards that goal, we started working and we did it, something like that. We digitized all the information and we have put it on the cloud. And there are another clause. There is another clause. Cross-country cloud is not acceptable. Your data has to be within a country. A lot of unclear guidelines are there still. So still things are debatable. People are working on it. But government is very clear. We have to work towards digitization very clearly. And how it reduce my cost, because we were keeping data in lockers in the place, on a rented place where it was basically occurring the huge cost of the rent and the maintenance. The moment you have digitized everything and put it on a cloud, so definitely there will be a cheaper rent was going only, that's it, right? So that's where you have saved it. Now coming to the another digitization, this is not in the hospital industry where I learned in the previous organization. A very beautiful project we have done is that was the centralization of the printing system, where we have worked on it on a printers, because every department requires a lot of printers. Give me one printer, give me one printer, and that way, at the end of the day, you see there will be maybe 200, 300 or 400 printer will be running in the organization, right? So definitely you will pay a lot of printing cost, paper cost, and the maintenance cost as well, right? So what we have done there, we have basically identified first of all the highest utilization areas, what are those, and the least utilization areas, what are those. We started eliminating least one first, and then we have built a capability where we have put in the high resolution printers remotely, which can do all those things. and the effort which you have to put it, you have to print, walk down, either you have to put your password to get that printout, right? This way we have basically eliminated the cost of the printing, toner, paper, and the third thing which we have applied there as a practice, your ID has to be printed on that paper. So that in case if somebody by mistake or by any chance like did it the printing, so he another person can pick up and he can basically help us to basically forward that particular file to or paper to that person. So these are the quite a innovation is around. By that we can achieve a lot of cost saving as well. So this is what is my submission is like through these small innovations we can make differences.
Thank you. Our prime issue is to save the patient. And now the technology is also there. You can take the printout via Bluetooth and Wi-Fi. HP is having such kind of vendors also. Now I request my fourth panelist, how we can reduce the basic cost of healthcare by basic introduction of the technology, even in the public sector hospitals or smaller 100-bedded, 50-bedded nursing homes or these setups. Please.
Thank you, Dr. Vicky. I am Dr. Deepak Agarwal. I am looking after the IT affairs. Although I am a neurosurgeon by profession. If you look at AIMS, which I think all of us know, is one of the largest healthcare providers in the public sector in India, and maybe in this region. And we are taking care of 3 million patients a year. So that's the number of patients coming into one campus yearly. And we are operating around 2.5 lakh surgeries per year. So it's a mammoth number, and providing cost-effective care remains the paramount consideration for these patients. And even before technology was introduced, AIMS was able to do that because that's the mandate of all public sector, I think, hospitals or any service provider to provide a cost-effective care. And we figured in Newsweek around 5 years back as being the most cost-effective provider of healthcare in the world. That was the front page news in Newsweek. So we have been doing it, but using technology, and this we have done consciously over the last 3 years, we have been able to really revolutionize our service delivery, improve the transparency and what I would say the quality of service which is there to the common man. I'll give you a few examples. For example, patients used to queue up right from 2 a.m. in the morning, standing in queues to get a number to be shown in the OPD. And those who were not, because everything's got a limit, had to again queue up again. So we devised a totally new appointment system with the help of an IC, and using this appointment system now, almost out of 3 million patients, 1.5 million patients every year are using the system, just over 1 year. So it's a huge achievement, and it was totally designed in-house by our own efforts. And this was showcased. The government of India took cognizance of this and took it as one of the 5 best projects in digital India and introduced it in Digital India Week, and now has mandated NIC to implement it across all hospitals which are under the central government as a first step. So this is in such a short period we have been able to achieve, because our mandate is not only for AIMS, but whatever technology we introduce should be usable across the nation in other hospitals. And I think this is one of the major success stories we had. The best part is, and we've been propagating it, is medical tourism we all know. And what we believe is it's only for the private sector. It's not true. If you look at major hospitals, and I would say AIMS is one of the major public sector hospitals, we get close to 50,000 patients from abroad every year, which could be bigger than any number in any private hospital. And this is, we're not talking about the US or the Europe, we're talking about the neighboring countries, from Bangladesh, Nepal, Africa. We get more than 5,000 patients from Africa coming to AIMS for treatment. And this is word of mouth. We are not advertising. These patients are consciously coming to AIMS to get treatment despite the long queues, despite Indian patients having to wait more than 1 year to get operated. Because there is no law which says that you have to discriminate between Indians and anywhere else in the world. And they get the same treatment at the same cost. And that is why they are happy to wait here, go through the same queues, and whatever technological processes you put in benefit, I would say, the world citizen rather than the Indian citizen. So it's a huge thing we are implementing in place. The second thing, example which I want to put across is, one of the major complaints was that we didn't have a reception counter to help feedback, grievance redressal, help patients in whatever stuff they want to do. And so we toyed with that idea, but we found that if you put a person in a government sector on this kind of a job, they all become bums. They will not be available on the seat most of the time, and if they are, they will try and break the system, because they will ask the patient, okay, I'll get this stuff done for you earlier, you give me 10 rupees or 15 rupees or 100 rupees, I'll get it done. So human contact, we realize, is the most detrimental factor for giving cost-effective quality care. So how do you remove the human factor? So we actually tendered for a call center, and we have now around a 30 seater call center for AIMS, outsourced. And this way, there is no human contact of the patient with the person in the hospital. So whatever information is unbiased, transparent, and everything is recorded. So for quality assurance purposes, if somebody complains, we can actually take their call center to task. So I think this is a very good example where you can decrease corruption and all kind of red tapeism when we're coming to improvement in citizen delivery of services. The third thing is, for any technology, it has to be visible to all stakeholders. So we did very simple things. We had display boards all over the place. For example, if you're getting operated, the display board will be showing how long is the surgery, how long has it elapsed, who's the doctor in charge, and what is the next step where the patient is going to go. So there are huge display boards outside the OT where the patients or relatives are waiting, because they have nothing else to do. And this is technology, because the back end we already have this system in place where the nurses are entering the time of incision, the time of when induction and everything. We are getting for our own quality assurance purposes, what is the workflow inside the OR, how long is taking for the case. So both stakeholders, the doctors, the system, as well as the patient relatives are being held by it. Similarly, we talk about printers here. If you look at the cartridge-based printers, any company, it will cost you around 1 to 2 rupees per print. That's the industry cost. And we have close to 5,000 printers and names itself. So you can imagine the enormous cost of printing. So then we explored the market and we found there were, people don't call them printers, but multifunction devices, which are toner-based, drum-based. And they are scanners, printers, and whatever, print photocopiers. They cost a little more, maybe 50,000 rupees a piece, but you get, with the vendor, you can get locked in the price per page of 30 paisa also for the next 7 years. That hugely brings down the cost of printing. So we had huge resistance. People said that why have you bought a photocopier and a scanner and everything with this printer? It's a huge thing. So when we explained that it's a very, very cost-effective option, we are saving crores a year just by buying this machine, which you use only for printing. We do not allow any photocopying or scanning or anything else on that, but it saves money. So there are solutions in the market already, which you can use to bring down your IT costs, and we've been using them. I think the other thing is, IT itself should not become too expensive. So if you have expensive solutions, and there are so many vendors in the market, it's a vendor-driven kind of stuff which is there. And if you look at in the US, Epic and Cerner, typical installation in a hospital will cost you millions of dollars. So obviously India cannot go in that direction and become bankrupt in a public sector thing, paying millions of dollars per hospital and a similar quantum 20% per year is the standard maintenance fee, it is not going to lead us anywhere. So we have to look at solutions which are more cost effective. What we have done is we have NIC is the government agency, we done used partly that, partly we use open source solution, partly in-house solutions. Because it's not that the proprietary solutions are not good, they're very good, excellent in fact. But if you look at the big picture, what we are doing for AIMS, we would like to believe that we can do it for the nation, in sense that for all the government-run hospitals. So this is like an experiment going on right here, and I think we are on the right track. And only time will tell whether the way we are taking will actually be implemented across the nation.
Thank you. Can I ask you one question? Just now, Prashant has delivered an eye-opening talk. As you have said, 5,000 printers are working in AIMS, and you have got toner-based printers. As Prashant has said, the toner particles are moving in the atmosphere, in the rooms via the air conditioning. Is the AIMS has got any quality control system for your technology, or is there any department who is looking after this? Because while we are basically concerned with the patient,
Sir, that's
as well as with the health of paramedical in the medical staff.
it's a very relevant question. My answer to this is, a lot of doctors are very, very fixated about a certain brand for a drug. For any generic drug, we give branded medicine, saying that this brand has better quality than the generic brand. Okay? And who is to, again it's industry driven, because the one brand of any generic drug will be costing 10 times more than the generic variety. Now this general explanation given is that no, we cannot depend on the quality given by the generic drugs. There is a standard government drug controller of India to maintain the quality and consistency of the drugs. As a doctor, I cannot say that this drug is worse. If it is in the market, for me it is legally safe to be used. If I have a concern, I should give it to the drug controller of India. But most doctors take the assumption that no, we will not prescribe generic drugs because they are spurious, they might be spurious, they are of poor quality, and we will only give the most expensive or what they are comfortable with. Similarly, when it comes to printers, if the printer is available, legally available, compliant with all, who am I to say that this is causing health? It is being used all over the world. Let it come in black and white with the government advisory that these printers should, and we will stop using it. So as a lay person, because I am a lay person when it comes to the quality assurance of printer and particles in the air and air conditioning, I am a lay person. There are many government agencies whose task it is to maintain it all over the world. Let the advisory come from there. That's my...
Thank you. Means your words, the quality of these printers and all those. This should be. I request to my fifth panelist to give his inputs regarding the effective technology related to the medical equipment, just in 5 minutes. Don't take my time, as I got the message that we are running short of the time. Because we have to give the chance to the delegates also.
Being Delhi, I'm forced to make a comment. Probably think of even day, odd day printing, you might say more printing. See, you're looking at effective use of technology, trying to reach some adoption. Couple of things is, all of this starts from home. So yes, there is mixed emotion on the budget. There's a lot of expectations from the government on regulation. Let's not forget how the stethoscope was invented. It was some piece of equipment which was told that people can't think of how a patient will be seen without being touched. Try to find a doctor without a stethoscope, or at least a photograph with a stent on his neck. It's change. It's change, and change has to be driven. It is a fact that legal rules around healthcare and healthcare IT and technology practices even if it is going to be the measurement of the toner quality that goes into the air, causing infection or other related issues. I think part of it is we'll have to start looking at it, because I think we are more faster on consumerization of it, more faster on looking at the legal angle of it, and sometimes forgetting the patient is the center of the universe of healthcare. And whatever is required for the patient, and in a world where there is a huge demand and supply gap for healthcare delivery to be given, for the amount of consumers who are aspiring for healthcare, he very rightly put it, saying the number of international patients that come to AIIMS definitely shows the quality of Indian healthcare standards. Right technology used by the right set of people with the right attitude of workflow and process efficiency will enable healthcare delivery to be really effective, maximized, and to most delightful clinical outcomes.
Again, somewhere we are behind. How this technology is reducing the cost of the healthcare.
Hi, my name is Prashant. I am representing Radiant Life Care, who is operating and managing two hospitals, one in Delhi by the name of BLK Super Speciality Hospital, and in Mumbai by the name of Nanavati Hospital. So I would like to touch upon three aspects of the costing and automation. So whenever we talk about healthcare IT, so we start from processes, automation, and care coordination, and now the important aspect is at what cost actually we should achieve all these things. So as a case study basically which we have practiced in our hospital, so I would like to share a cost efficiency part of it. So with the help of technology, so this journey actually started in the year of 2014. So when we started taking out the costing parameters of speciality of a doctor and going to the lowest level to the level of a procedure or package. So initially actually when the journey started, so we interacted with the medical fraternity and we started saying that, sir, this is the package, so we are taking out this particular package, so we are incurring this much of cost. So there were a lot of resistance actually which we used to get from the medical fraternity. So now, with the help of technology and to the level of extraction of the data, to the level of contribution of a procedure or a specialty or a doctor actually, now the things has literally changed actually in our hospital. Now a doctor, whenever they want to use a new consumable or they want to start a new package. So this is very strange that now actually they refer to the costing department through the technology and they say, can I use this consumable? What is the costing? So with the implementation of all this technological innovation, actually we could increase the EBITDA from 10 to 15%. That is a huge growth as far as, and we could reduce a lot of packages cost actually. So which gives the cost optimization for the patient as well. So in totality actually, so it is reducing the cost for the patient and increasing the cost, the profitability for the management. So there are two aspects basically. One more thing I would like to share, as the the agenda of the meeting is patient delight. So we just started a module. Coincidentally, the module's name is also patient delight. So what we are doing is we are covering the 360-degree approach of the patient in terms of the complaints, in terms of the feedback which we get from the patient. So you'll be surprised actually there's a huge number of patient satisfaction which has increased in our hospital actually, right from 80% to 95% actually it has gone. So what we are doing is right from the patient interactions, whether the interaction is being done by the admin round or from the clinical fraternity or after the patient is getting discharged. So we are sending an SMS. So whole life cycle has been automated and we are getting absolutely transparent results as far as patient feedback is concerned. So this is really giving us to the new level as far as patient satisfaction and the costing is concerned.
Thank you. Definitely technology has improved the healthcare as well as the education. More in the education. Still, there is a lot of requirement to be improved in the medical sector. I request to my last panelist to sum up again with the technologies we can reduce the cost of the healthcare in the villages or basic system.
I think I'm not the right person to comment on that because all this hospital stuff. By the way, I'm from a company. What I can add couple of points when we are talking about technology to patients' delight. So there is apparently a shortage of 10 lakh beds in India, which we are not able to fulfill or not the capacity building. So I think the average hospital stay because of hospital-acquired infection increases by 3 to 4 days because of hospital-acquired infection. If we are able to reduce this by using technology, smart technology, and we are able to release the patient pretty quickly because of avoiding hospital-acquired infection or minimizing that. That is what I can I can add about technology. And regarding IT, IT can be used for reducing waiting times of the patient in the waiting room. That is AIMS is very great to know that AIMS has already achieved something in that direction, and I hope all the hospitals across India can use that. Well, patient awareness and training using digital technology to make patient aware, or other lifestyle awareness, lifestyle disease awareness, or chronic care management using IT enabled services. That's what I can add. Means this is what is required. That's all from my side.
Thank you very much. Now house is open for 5 minutes to the audience or any question.
Good morning to you all. I'm Dr. Sanjeev Sood, and thanks for sharing your valuable insights and inputs on the technology, by which I think you mean the ICT as well as the biomedical equipment can help in quality improvement, patient safety, as well as the cost containment. So coming to the last part of cost containment, though you repeatedly asked this question, the various panelists, but to exactly know how to reduce the cost will depend if the hospitals are willing to share the EMRs amongst themselves. So EMRs, though hospitals have developed within their own organizations, but to share it will mean sharing of the intellectual property and willingness to let their patients go to the other hospitals, which may not be acceptable to most of the private hospitals. And secondly, certainly the cost will come down because the EMR will help us in reduction of the over-investigation of the patient. Once we have the results in front of us, the patient has undergone these many investigations already from an accredited lab, or he or she is, has allergy or adverse reaction to certain drugs, and will certainly reduce the cost of the adverse medication and adverse events. Then secondly, in the area of the inventory management also, the efficient management of the inventory by barcoding will reduce the wastage as well as the pilferage. And most importantly, the way with which the cost containment can be achieved is improving the operational efficiency of an organization wherein the turnaround time is reduced. So what we achieve by this is that the more number of patients, the average length of stay will reduce. Certainly by implementation of the HIS and HMIS, most of the hospitals would have reduced the average length of stay in the organizations, which will enable them to treat more number of patients on the same number of beds, beds being the scarce resource in our country. So that is the way I looked at how ICT can help in cost containment by allowing more and more patients to be treated on fewer beds. Thank you.
So we have Gramal Swast head, Colonel Badam with us. He had joined the session just about 15 minutes back and I missed valuable speakers' comments. But I am from the have-not side. I am not exactly with the haves, I am with the have-nots. Birabal Swast is presently operating in villages and most underserved areas. And we are running various platforms like medical mobile units, we are running PHCs, we are running telemedicine centers and health helplines across 11 states pan-India. I'm so glad to see Mr. Leakey here because I met him when he had come to Bagar and we showed him how we are operating our mobile medical units. The point that I want to bring out is that as the infrastructure which has been devised at the level of the villages and districts, as far as ASHAs, ANMs, Anganwadi worker, GNM, doctor, CHC is concerned, it is fantastic. Policymakers have really devised a beautiful structure. Only thing is, what is lacking is execution. And that is a very, very sad point. But the light is that the government has realized that though health is their responsibility, but it is not possible for them to do justice to this job unless they find a partner and they make a private-public partnership like we are doing in case of Rajasthan. We are running 13 PHCs on behalf of the state government, and what a tremendous change it has been. I want to just bring it to the notice of the august audience here that the OPD rate has increased by 38% than what it was in the last 3 to 4 months. And the system is working very fine. And if you follow the sustainable health goals, then we are focusing on MMR and IMR, where we require saturation, where we require the data of all the pregnant ladies and infants. And to get the technology to do it for us, we have to evolve further from here. It's a process of evolution, we are learning. And as recently I heard in the previous session, Mr. Secretary who had come, Mr. Jalani, he mentioned that we have given tablets to ANM staff. Now these tablets are also to be given to the ASHAs, and we have to make such linkages, which is IT based, technology based, that it becomes easier for us to monitor the health of the people effectively. I will also like to bring out that we are also working in areas which are tribal areas. I have recently visited Arku, which is an Andhra Pradesh, hill station of Andhra Pradesh, where there are 180 habitats we are taking care of, where we have to walk about 8 to 10 kilometers in the hilly terrain and reach those people, those habitats there. We have an outreach workers, outreach agents who go and deliver medicines to them, do the ANCs, carry out tests, and this is something area where I don't think many of us are aware of it. I came to know how the health is in village only once I joined this company. Before that, I was totally unaware of it because I'm an urbanite. And there is leadership required here, definitely. And it is, firstly, I would say, it's a process which is evolving, and our focus should also go to the primary health care of the villages and the people who are underserved, that how best we can get the technology and how best we can facilitate that. We can give practical inputs, we can guide, we know which are the gray areas, we know what are the deficiencies in the system, we can be a great guide. But as far as the vision is concerned of the government to partner with the private players, it is fantastic. If there is an innovation, the innovation is in the vision. The innovation in the medical devices are there, but innovation in the vision is also there as far as the government is concerned. I just wanted to bring out this perspective since I had an opportunity to be present here. Thank you.
Thank you very much. I sum up it. Definitely, technology is beneficial for the healthcare system, for affordable, accessible and quality healthcare. There is no doubt that technology, even you just see a mobile, a rickshaw puller is also having a mobile. and many of the apps are there. You can download for the reservation, for health, as well as the Delhi government has announced for the OPD registration, right from your mobile, use that mobile for care and all that. There is no doubt that technology has reduced the cost of healthcare. But time is required. And on the other side, if regulation is required. Why regulation is required? A legal aspect of this technology is definitely required. And for the quality of technology. Because in our country, the healthcare system is very much patchy. Somewhere something is going on, somewhere something is going on. So these things are required. And then I thank all my panelists and all my audience. Thank you very much.
Thank you very much, Dr. Lekhi, for a wonderful moderation of the session on healthcare delivery and hospital management. I request now Dr. Lekhi to present mementos to honorable panelists which are there on stage. And we'll start with Dr. Deepak Agrawal, Chairman of Computerization and IT Head of AIMS, New Delhi. A round of applause for Mr. Deepak Agrawal. Mr. Arvind Sivaramakrishnan, CIO of Apollo Hospitals. Mr. Vineet Purushothaman, CIO of Fortis Healthcare Limited. Mr. Kapil Mehrotra, CIO of Artemis Hospital, Gurgaon. Mr. Prashant Singh, CIO of BLK Super Speciality Hospital, New Delhi. Dr. Shaktin Bajaj, Director of Sickness Hospital, New Delhi. Last but not the least, industry expert, Mr. Dilip Patil, Managing Partner of Trivector Bioment LLP. I request for a group photo with their mementos in their hands, a group photo. And I also, before that, I request Dr. Agrawal to present a memento to our session moderator, Mr. Dr. Lekhi, for this wonderful moderating of this session on a very important issue of healthcare delivery. A round of applause for Dr. Lekhi and all the panelists. A group photo is required.